Well, first, thank you very much for inviting me, and I bring a big hug from the current president of the FIGO, the International Federation of Obstetricians and Gynecologists, who is very much involved in exactly what you are doing and very committed to help in any way that he can do to see that your purposes are achieved. Well, first, the subject of my conference that I have agreed with Rodica was what is said here, the role of post-abortion contraception in abortion care. And my claim is that it's not always recalled that part of abortion care is counseling and provision of safe abortion services. Okay. Well, the purpose that have been talked about here many times is to prevent unintended pregnancy that may or may not lead to abortion. And we all agree that every woman has the right to be able to decide when to get pregnant. And that means to have full information on reproductive physiology and contraception, and to have access to all contraceptive methods. And my argument is that women having an abortion have a specific reason to have a preferred access to those two rights. And I'm going to talk on why post-abortion contraception is so important as a component of abortion care, why the contraceptive method should be initiated immediately following abortion, why the preference for long-acting contraceptives, and I'm going to talk a little more about that later. And the final question is, can acceptance rate of this long-acting method be increased when provided immediately after abortion? Answer the first question, why post-abortion contraception is so important in abortion care. And the first reason is because the woman who come with an induced abortion or requesting a legal termination of pregnancy is telling us by her behavior, her firm decision not to have a child. I mean, people have an abortion because they don't want to have a child, and that is very strong in them. And if they become pregnant again soon, she will resort to another abortion. The second reason is that because the woman who presents with an incomplete abortion or requesting a legal termination of pregnancy is motivated to prevent another unintended pregnancy and is open to appropriate counseling and provision of services. The third, because the woman is already in a health facility and receiving care from a professional who have the capacity to provide the contraceptive method that she may choose. The second question is, why start the method immediately? Well, because the probability of initiating the use of a method that they choose decreases, and the risk of unplanned pregnancy increases when the use of the method is initiated later, if she is referred to a family planning clinic instead of providing the method within the facility where she is having the abortion. And here is an example of that kind of experience, and you can see the side of the column shows there the percentage of pregnancy in the first group of columns, abortion and births, when the contraceptive is given immediately before leaving the facility where the woman had abortion, or is delayed for a later period. And you see that the proportion of pregnancy is about half, and the same in relation to abortion and birth when the method is provided immediately after the abortion before the woman leaves the health facility. This is another study by Dr. Cameron from Scotland that shows the relative risk of repeated abortion according to the method used after the previous abortion. And here I am talking now about a long-acting method. The reference used is to women who leave the abortion clinic using a pill, which is the risk of 1. Those who use an IUD or an IUS, the risk is 20 times lower, 0.05. So the effectiveness to prevent a new abortion if the woman leaves the facility with an IUD or an IUS is 20 times lower than if she leaves using the pill. And I believe that partially explains the French problem of large increase in the proportion of contraceptive users and no change in abortion. If you look at the lower line there, those women who leave the facility using no method is not significantly different. The risk of having another abortion in the year after the previous abortion is the same if they leave the clinic using no method that if they leave using a pill. A difference is with the use of the IUD is 20 times less. If they leave using an implant, it's very similar to using an IUD. And if they leave using a 3-month injection, they have half of the chance of having another abortion compared to those who use the pill. But it's still 10 times higher than if they leave using an IUD. So that may explain why to increase the proportion of women using modern method is not enough if those methods require repetition of their use. And I'm going to explain that a little further. Why the preference for long-acting method? We all recognize that the woman has the right to be able to choose which contraceptive method should be used, and we cannot impose the use of a long-acting method after an abortion. But the woman also has the right to be fully and correctly informed at the time of choosing a method. And what we usually inform is the effectiveness of the method that is reported by the pharmaceutical industry. Because there is a difference between the actual efficacy of the method and that reported by the industry. For more than 3 decades, investigators have been noticing the marked difference between the efficacy of some methods in controlled clinical trials, which is what we usually report, and to what is found in population-based studies. Russell, who is an economist and not a physician, introduced the concept of failure rate of method during perfect use, which is during clinical trials, where women who don't use the method properly are removed from the sample, and the failure rate during typical use. This is in real life data obtained from population-based studies. Take the example of the oral contraceptive, the pill. Its efficacy depends on the ability of the contraceptive pill to inhibit ovulation, which is very good. And that is why the perfect use is very high, failure rate is very high. But they also depend on the woman's compliance with the daily pill taking, and even more important, with the prescribed pill-free interval that cannot be longer than 7 days. The lack of compliance with the daily pill taking and with the pill-free interval increases the risk of escape ovulation and consequently of pregnancy. And the same applies to the contraceptive patch, the vaginal ring, and even to injectable contraceptives. If the interval is prolonged, the risk of ovulation increases and the risk of pregnancy increases in parallel. That's why the actual efficacy during typical use is different for short-acting method, but in long-acting reversible contraceptive, which you cannot forget. I mean, you cannot forget the IUD is there, you cannot forget the implant is there, but their typical use effectiveness is the same that the efficacy in perfect use. Depo-Provera, which is the 3-month injectable, is an intermediate case. However, unlike the method that lasts for years, the efficacy during typical use is much lower than during perfect use. For this reason, there is a considerable difference in the definition of which methods are highly effective according to whether the pregnancy rate during perfect use or during typical use is taken into consideration. This is the pregnancy rate reported in general during the first use of a contraceptive method, which is the result of controlled clinical trials. And this is what is usually reported. And you can see there that the combined oral contraceptive pill have a pregnancy rate of 0.3 after 1 year of use, and the same for the ring, and the same for Depo-Provera. And the levonorgestrel US appear as just slightly better. The implant the implant is a lot better, and they are not different between the pill and tubal ligation, and are very close to vasectomy. The copper IUD appear as less effective than the pill and the ring and Depo-Provera. However, if you look at a pregnancy rate during typical use, that is in the column to the right, you see that there's a big difference. The combined oral contraceptive have a typical use pregnant failure of 9. That means a North American woman, because all these studies are done in North America, of 100 North American women who start using the pill, 9 will be pregnant by the end of a year. While of 100 women using the copper IUD, less than 1 will be pregnant at the end of the year. In the case of the implant, less than 0.1 will be pregnant at the end of the year. And so there is a big, big difference between perfect use, which is usually the effectiveness reported to the woman, and typical use, which is the information that the woman has the right to know. So this will be the real information that we should give to the woman. That all these 5 methods in the upper part of the figure are those who are really highly effective, and those who are below do not have the high effectiveness that is usually reported based on clinical trials and not in real life. That is what the women need to know when they are deciding what contraceptive method to be used following an abortion. The practical experience has confirmed the higher efficacy of long-acting reversible contraceptive in reducing the incidence of repeat abortion. In this figure, you have the repeat abortion rate per 1,000 women years, according to the type of method and whether it was provided immediately following abortion or later. You see that the number of women pregnant 1 year later of every 1,000 women is only 18 for long-acting method, is the double for short-acting method, and is even greater if the woman did not start to use the method immediately. And the other thing is that the use of drug is particularly important for adolescents who need to postpone a pregnancy. And this study shows in the upper part their comparison of the probability of not becoming pregnant. The closer to 1 is that they did not, no one got pregnant. It's practically the same for younger and older women that were using long-acting reversible contraceptives. While if they are using short-acting method, the difference between younger and older women are very high. The fourth question is, can acceptance rate of this long-acting method be increased of what we currently have? There is one study done in the state that answered that question. And the acceptance rate depends on the availability of no-cost contraceptive method, and that's the problem, the cost of the method. And some discussion about that has been run in the earlier presentation. If the methods are made available at very low cost or free, the acceptance will be naturally much greater. And this is a study, which is called the CHOSE study, in which the methods were offered to women 14 to 50 years of age who wanted to avoid pregnancy for at least 1 year. And there was counsel explaining the data that already told you about the typical use effectiveness of the method. And the method was offered at no cost. And 2/3 of the 2,500 participants choose a long-acting method. But when women are informed of the real effectiveness of the method, they tend to choose long-acting method. 56% was introducing device, and 11% was subdermal implant. In some other places is the opposite, but this is not important. What's important is you want to have high effectiveness, you need to choose a long-acting method. It's also dependent on the training and attitude of the providers, and this is something that has been discussed with relation to provision of abortion care, and the same towards the provision of contraception. It's a question of training, and it's a question of attitude. I don't know how it is in your countries in this region, which I don't know, but in Latin America, many physicians prefer to prescribe a pill because it's less work in that insert an IUD or insert an implant. So the question of attitude of the provider is extremely important. It's not enough to be trained. You have to be willing to take a little more time to really protect the woman that you are taking care of. And the other thing is an organization of the system. In many countries in Africa where we have been working on it have been very difficult to get the IUD and the implant in the same place where the abortion is being carried out or the incomplete abortion is completed. Because you can insert the IUD immediately as soon as the uterus is empty, and you can insert the IUD in the same procedure. That will not take much time, so the attitude is not so important, because it will take just another minute to insert an IUD immediately after the abortion. The question is that the IUD is there, together with all the equipment required to empty the uterus. So the question of organizing the services to be sure that the method is in the same place where the abortion is being carried out, or is completed in case of an incomplete abortion. In some countries in Africa, because the implant is not that easy to insert immediately after abortion as the IUD, but nurses have been trained to insert the implant, and there's no secret in inserting an implant and removing an implant. And so it's not the doctor because he's too busy, but the nurse who inserts the implant immediately after the abortion. So it's a question of organization of the system to provide the counseling and the immediate provision of the method to get that the woman live after an abortion protected against another unintended pregnancy that they clearly do not want. In conclusion, there will always be unplanned pregnancy and induced abortion because no contraceptive method is perfect, but we can contribute enormously to reduce the number of unintended pregnancy and the burden of abortion to women if we organize ourselves to increase acceptance of post-abortion contraception. First, and second, with preference for the use of the method who are in fact highly effective if the woman chooses them, but they have to make the choice knowing exactly which is the real effectiveness of the different methods that they can choose. Thank you.